Okay, so now that we've talked about how to diagnose insomnia, we've talked about stages of sleep, why we sleep, all this wonderful stuff. It's time to talk about treatment of chronic insomnia. And chronic insomnia actually has some pretty beneficial non pharmacological or non medication interventions that can be very useful in treating. That includes CBTI, or cognitive behavioral therapy for insomnia. This is actually considered our first line or gold standard from the American Academy of Sleep Medicine. If you can find it, if you can get the resources to do it. So CBTI is a psychotherapeutic method similar to other types of cognitive behavioral therapy that helps to reframe. It reconstructs our negative associations with sleep to positive concepts. And this is typically used in combination with relaxation and stimulus control. So relaxation and stimulus control are ways to teach someone to form positive relationships and to engage in kind of a cool down, if you will, when going to sleep. Relaxation training or relaxation control is a way to engage in sequential muscle relaxation typically with guided imagery, as well as breathing techniques to help reduce that arousal state, that awakened state that can be difficult to come out of when trying to sleep. So the arousal state physically can kind of feed into the mental arousal state as well. So they're somewhat connected. So by physically relaxing the body using guided imagery, we can gain a sense of calm and help us sleep. The stimulus control is really establishing a good series of habits when it's connected to sleep. So having a consistent schedule, having that structure. Structure is so good for mental health in general. In particular, it's helpful for sleep-wake. So in addition to that, connecting the bed with sleep, right? So we do a lot of things that we probably shouldn't do in bed a lot of times. Engaging in watching TV or eating or whatever, things that aren't really connected with sleeping. And that's not necessarily a good thing if you're having trouble sleeping. We also have sleep hygiene, and sleep hygiene is an educational tool to help people establish a better connection with how to sleep, when to sleep, the pieces of that. But typically just education with sleep hygiene is not effective alone for treatment of chronic insomnia. Again, sleep hygiene is not a catch-all that's going to fix everything. We don't use it alone when it comes to treating chronic insomnia, but it can be a useful tool in our toolbox. Okay, my slide. Hold on. Boop. Okay. So aspects of sleep hygiene. So sleep hygiene is a lot about things that kind of make sense from a common sense perspective. So having a regular schedule, trying to go to bed at a same or similar time and waking up at a same or similar time. Having a bedtime kind of wind down routine. All the stuff that make us feel physically well. So things like regular diet that's balanced and being active. Having a quiet, cool, dark sleep environment. And then there's also things we should avoid when it comes to sleep hygiene. So avoiding things like naps. Now, naps are sometimes useful if you have a pathological condition of hypersomnia, such as narcolepsy or idiopathic hypersomnia. But it's not useful when it comes to insomnia, okay? Because it can throw off your sleep schedule. So nap attacks, not a good thing. Other things to think about: caffeine, water, and alcohol intake. So late night intake of any of these can disrupt the quality and ability for one's sleep. So trying to avoid drinking a lot of water right before you go to bed, drinking a lot of caffeine, especially if you're sensitive to caffeine, and even drinking alcohol, because again, the quality of sleep is not a great thing if you do that. Electronics, so the light, the shining light in our face when we go to bed. If you have a phone, a laptop, a TV playing, that can be distracting and can actually make it much more difficult to go to sleep. So these are all kind of common sense things. They all make sense, but I know a lot of us tend to do these types of things, and it can impact our ability to maintain sleep or to go to sleep. Sleep should be, or beds should be reserved for sleeping and sex, right? And that's pretty much it. That's what we should be using beds for. But a lot of times we don't. So things to think about if you're having trouble sleeping. Now, when we think about medications that can be used to help with chronic insomnia, there are over-the-counter medications and there are prescriptive medications. So we're going to talk a little bit about some of the over-the-counter medications and what some of their potential risks versus benefits are. And the first one that bears discussion, of course, is diphenhydramine, which is benadryl. So diphenhydramine actually is found in a variety of sleep-promoting products that are over-the-counter. This can include Tylenol PM, ZZ-Quil, whatever. A lot of these products that are trying to upsell you for a sleep product is just diphenhydramine. So Tylenol PM, for example here, is Tylenol plus benadryl. Okay, then you can get this much less expensively, number one, by purchasing them separately as generics. But number two, diphenhydramine is an antihistamine. And there's some risks with taking antihistamines long term. The effectiveness of the sleep induction tends to wear off over time. And the effects, they have these drying effects we call anticholinergic effects. And anticholinergic effects over time appear to potentially contribute to, especially in our older adults, things like cognitive decline, like dementia, right? So we see constipation, we see urinary retention, dry eye, dry mouth. It dries you up, which is part of the benefit with antihistamines. If you have a runny nose, a Benadryl type antihistamine can be helpful for that, but long-term use probably isn't super beneficial. There are, however, some natural over-the-counter products that can be beneficial. Melatonin, valerian, chamomile. There are some risks with these products. I'm not going to go into too much detail. Valerian I typically don't recommend. Chamomile, especially if it's like a tea, is not super effective, but usually it's kind of that low risk, low reward type scenario. But I do want to talk about our melatonin products. So melatonin is a product that's synthesized from serotonin in the pineal gland. Remember we talked about the brain pathways and the circadian rhythm. So melatonin is something that spikes during darkness. So it helps to signal the brain to go to sleep. It's what we call a chronobiotic, so it adjusts the timing of internal biological rhythms. Now, typically when it comes to dosing, people don't always dose melatonin appropriately. Dosing of melatonin, you should get a good product that is lab tested, that, talk to a pharmacist. I'm a pharmacist. Hey, talk to me. Pick a product that is a high quality product, and they'll try to upsell products with a bunch of other like elderberry and like weird stuff in it that doesn't really have a lot of data to support its benefit. Generally, you can get just basic run-of-the-mill melatonin that's a reliable product fairly inexpensively. Now, people will sometimes take it like right before bed, and it needs time to work. So I usually recommend taking it at least an hour, but 2 to 3 hours is totally reasonable to take melatonin before bedtime. So you actually would take it earlier than you might think would be reasonable to. And dosing. So there's some potential risks for high doses of melatonin that we don't fully understand because it is something that our body makes. The potential long-term effects of chronically using large doses of melatonin may have impacts on our body's natural production of melatonin. And it's not really clear. I generally recommend 3 to 5 milligrams. Higher doses probably won't confer much additional benefit, and the risks really aren't clear, particularly long-term risks. Lower doses for some people do work, but oftentimes it's children and things like that. The effects for children, we don't have as much data about either, but it is oftentimes lauded as this natural way to promote sleep. And from a risk versus benefit perspective, if it's a good quality product, it appears to be pretty low risk with some fairly good benefit. It doesn't tend to be super beneficial as an as-needed product. So we use it a lot in regulating sleep cycle for people who have jet lag, trying to push it back into a a standard circadian rhythm. We will use it sometimes in our older adults that have those awakening issues to try to signal to their brain to sleep and stay asleep. But a lot of times the recommendation is for taking it multiple weeks for it to really work. It's not as effective for most people as an as needed thing. Everyone's a little different, but in general, this would actually be something that you would take pretty consistently. Now, on the other side of things, there are a number of prescriptive medications that can be used as treatment for insomnia. Now, most of these are really designed to be taken for 2 or 3 weeks, not for extended periods of time, but you will sometimes see people who are taking these types of products for longer periods of time. Particularly our short-acting benzodiazepines and our non-benzodiazepine GABA agonists, also referred to as Z drugs. So you will see people on these long-term. Sometimes we do resort to that if they've tried everything else. They have no other issues, no other challenges, and we just can't seem to get them to sleep without it. That can happen from time to time. The other products that we use sometimes are orexin antagonists. We have a melatonin receptor agonist, which is not the same as melatonin itself, but it works on the same receptor. And then there are some non-FDA approved products that are antidepressants that are known for having sedating properties that are sometimes used to help treat chronic insomnia. So we look at benzodiazepines. I'm not going to go into the same detail that I would if I was talking about it in an anxiety context, but we're really just talking about it as a kind of 30,000 foot, how is it used in sleep? So benzodiazepines work by promoting GABA. Okay, so these products are GABA receptor agonists. They actually bind to the site that's separate from the GABA neurotransmitter itself to increase how frequently the chloride channel in the cellular membrane opens, which allows greater activation. There are a number of products. These are not all of the benzodiazepine products that are on the market. These are ones that have specific indications for insomnia. So someone might be prescribed Ativan or Klonopin or Xanax, right, for sleep. That can happen too. These are the ones that are more specifically for insomnia. So these tend to be shorter acting benzodiazepines versus say like a Klonopin or a Valium, so clonazepam or diazepam, which are longer acting. So they're going to still be kind of in effect after someone wakes up in the morning. All of these products are known to cause some challenges too, things like confusion, falls, increased risk of fractures, particularly in our older adults and young children. And we have to be a little bit careful when we're using it in our older adults because there are those types of risks associated with it. There are also a number of issues with using particularly long-term benzodiazepines as a hypnotic, and hypnotic here means a medication to promote sleep. So there are a number of effects that when taken repeatedly decrease in benefit, if you will, over time. So for benzodiazepines, the effects on the seizure threshold, so it can treat seizures, but not long term because the seizure threshold kind of adjusts to it over time, and sleep. So when individuals take benzodiazepines long term, they slowly become tolerant to the sedative effects, the hypnotic effects of the product. And then what we'll see is they'll require larger doses of it in order to achieve the same desired result. And that can have its own inherent risks of high doses of benzodiazepines. Abrupt cessation or stopping of benzodiazepines can cause rebound insomnia, so difficulty sleeping as a withdrawal essentially from the benzodiazepine. But it can also cause in high doses for a long period of time if we stop them suddenly. And typically if it's for insomnia alone, it's usually not high doses, long-term, constant exposure to benzos, but it can cause things like seizures. And we'll talk more about that in anxiety type lectures when we talk about that. They also are known to increase the duration of our non-REM type 2 sleep and decrease our slow wave, so 3 and 4 in REM sleep. We can also see people experience what's called next day drowsiness or a hangover effect, so they may not be fully cleared out of their system come morning, so they may have some residual impairment from the medication. And there is actually an overall reduction in life expectancy. Now, for some people, that is this is going to keep them functioning. This is important for them to take. So I'm not encouraging anyone who's been taking benzodiazepines for a long time to just stop them. It's more understanding what some of those risks versus benefits are. And they're going to be a little bit different from person to person. We then have our non-benzodiazepine GABA agonists. So these are our Z drugs. So, and they're called Z drugs because all of the names have Z's in them. So these actually selectively bind on similar receptors. They're benzodiazepine receptors to promote GABA. They don't have as much effect on things like anxiety and seizures, so they work a little bit differently, but that's for another day. That's a much more detailed discussion to have. But their products that we use are Zolpidem or Ambien, Zaleplon or Sonata, and S-Zopiclone or Lunesta. Now, similar to our benzodiazepines, these all can cause confusion. They can increase risk of falls and fracture. They can have increased side effects with adults that are older, so older than 65. And if someone takes the medication with a less than full night's sleep, there is a pretty good risk of what we call next day impairment or the hangover effect, right? So you'll see if you read some of the information on these products, they'll say, don't take if you can't have a full night's sleep, because we don't want people waking up in the morning and then going and driving a car impaired. We want to make sure that these products, they're designed to be in the body and pretty much out of the body by the time you wake up. Now, these and benzodiazepines do have a risk of misuse and dependence. So, they are scheduled medication, controlled substance medications. With inappropriate use, there can be risk of withdrawal. There can be overuse, overdose. There are some challenges with these products, but they can be very beneficial for people who are really struggling to sleep. An additional group of drugs that we have, these are a bit newer. These are orexin receptor antagonists. So essentially what orexin receptor antagonists do is they turn off the wakey button, right? So they work on hypocretin or orexin. So instead of promoting sleepiness like we would with a GABA promoter, right? So GABA was one of our neurotransmitters that is sleep promoting. We would shut off the orexin or the wakeful promoting products. So kind of like antihistamines will sort of do a similar thing. These products, suvorexant, limborexant, Balsamo Dayvigo, they should not be used as someone who has narcolepsy. So some of the pathophysiology of narcolepsy is actually a hypocretin or orexin deficiency, right? So these are not to be used in people who have a diagnosis of narcolepsy. Now, this is true with other products too, which we didn't talk too much about, but there is a risk of what we call complex sleep behaviors. And we do see these in particular with our Z drugs as well. So the non-benzodiazepine GABA agonists. So this can be sleep driving, sleep eating, etc., while not fully awake. So there are some risks with these products as well. Then we have our melatonin receptor agonists. So these are basically melatonin analogs that will interact with our melatonin receptors. So the prescriptive one that is used for insomnia is Rosarim or Ramelteon. These can be used longer term. So these are not controlled substances. They can be used longer term, have more long-term safety data associated with them versus our 2 to 3 weeks that we see with our controlled substances. There's also a product called Tasimelteon or Hetlios, which I'm not going to spend too much time talking about because it's used really more specifically for that non-24-hour sleep-wake disorder that's associated with true blindness. Now, outside of our FDA-approved products, so those products are approved by the Food and Drug Administration for treatment of insomnia to various degrees, we have things that are called sedating antidepressants. So there's a variety of reasons why an antidepressant might be sedating. Now, we're going to have a depression stuff that if you're in the course that I'm teaching this and you're not just watching YouTube, that we'll talk about in more detail. But a lot of these will have things like antihistamine properties, right? So they'll have some antihistamine properties. They may affect serotonin in certain ways to promote sleepiness. Amitriptyline or Elavil, that's a tricyclic antidepressant, as well as doxepin. Now, there's also a low-dose doxepin that is approved for sleep. So that's the Silanor. So it's actually quite a low dose. It's really kind of unique in that sense, harder to get because it's still brand name, so it's going to be a bit more expensive. We also have mirtazapine or Remeron, paroxetine or Paxil, although that's going to have a lot of that anticholinergic drying effects, antihistamine effects that may have some risks associated with it, and then trazodone or Desirel. So these are our antidepressant products that are most commonly utilized as potentially a sedating product as well. Now, if you have someone who has depression and insomnia, you may reach for one of these to use to kind of kill two birds with one stone. But a lot of these aren't really, so that like our amitriptyline and doxepin in particular are not first line for depression. So we usually don't use them initially for that because there's more side effects. But sedation is one of those side effects. So something to think about when you're trying to choose medications for a patient, right? There's a lot of pieces to that puzzle to individualize medication options for people. So to review the general algorithm, what we do when we're looking at someone who's presenting, who's coming in and complaining of difficulty sleeping. So we'll evaluate the insomnia for other etiologies, other causes, but then we're going to look at if it's short-term versus chronic. If it's short-term, you can do sleep hygiene, and then using some short duration of a medication may be appropriate depending on the situation. So that could be our benzodiazepine receptor agonist, could be Ramelteon, and then evaluating for response. If they don't respond, then we're going to move into some of our other products like suvorexant, trazodone, or other benzodiazepine type drugs. If someone has chronic insomnia, then we're going to make sure that we really try to get them in with a CBTI, right? So cognitive behavioral therapy for insomnia, plus or minus sleep hygiene. Sleep hygiene is kind of a dime a dozen. Most people will offer it anytime there's some sleep challenges for someone. We make sure that there's any underlying medical or mental health challenges that aren't being adequately treated. We want to make sure that we're addressing those, and then adding that benzodiazepine receptor agonist if necessary, and kind of moving in from there. So this is our kind of 30,000 foot view first line approaches, and it can get really challenging for people. Some people end up on these long term. Some people are able to get through CBTI and get their insomnia under control. It's really based on the individual, but that's kind of our basic overview of these types of products before we talk about more specifically about some of our other sleep disorders and what their therapeutic options are as well.